Are we ready?
Yes, doctor, we are live now.
Thank you. Good evening, respected seniors, distinguished faculty, dear colleagues, and young ophthalmologists. On behalf of TNOA, it gives me immense pleasure to welcome you all for this special webinar on iconic institutions in ophthalmology, where we celebrate one of the most extraordinary success stories in global eye care, the ARAVIND eye care system. When we speak of institutions that have transformed ophthalmology through innovation, efficiency, compassion, and scale, ARAVIND stands as a shining example to the world. It's not merely a hospital system. It's a movement that proved that excellence and equity can walk hand in hand. At the heart of this remarkable journey was its visionary founder, Dr. G. Venkataswamy, affectionately known as Dr. V. His foresight was extraordinary. After retirement from government service at an age when many slow down, he dared to dream of eliminating needless blindness through a sustainable model of high volume, high quality, affordable eye care. His vision was revolutionary in many ways, that no person should lose sight because of poverty, that system and discipline can multiply compassion, that quality care can be delivered at scale without compromise, that service becomes powerful when guided by purpose. From a small beginning in Madurai, ARAVIND grew into a globally admired institution, serving millions, performing countless sight-restoring surgeries, training professionals worldwide, and inspiring healthcare models across disciplines. Equally admirable is the continuing legacy of ARAVIND. Great institutions do not depend on one individual alone. They endure when values are transmitted across generations. Today, ARAVIND continues to lead through innovation, community outreach, research, training, and unwavering dedication to patient-centered care. The founder's spirit lives on in every surgeon trained, every patient served, and every life transformed. As we reflect on iconic institutions, ARAVIND remains in the forefront as one of the most important institutions, which has true greatness is not measured only by building or technology, but by vision, values, leadership, and impact on humanity. May today's session inspire all of us not only to become better clinicians, but also to think bigger, to build systems, nurture teams, and leave behind meaningful legacies. We can start the session, sir. Thank you.
Thank you, Dr. Sujata, for the nice introduction. Respected President TNOA, Dr. Sujata, and President-elect Dr. V.R. Vijayaraghavan, and Vice President Madhavan, and my dear Secretary DC and Sriram Gopal, and other office bearers, and a galaxy of senior ophthalmologists from our own ARAVIND eye care system, and my dear delegates and friends. Good evening to all of you. And also, it's my pleasure to welcome all of you for this wonderful webinar on iconic institutions that have shaped Indian ophthalmology, the past, present, and the path ahead. Today, we are going to have our ARAVIND eye care system presentation. And of course, I have to thank Dr. Sujata for giving this wonderful platform to showcase our achievement in the last 50 years. And also, I have to congratulate Dr. Sujata for doing wonderful work and her team. That innovative work what she is doing for the last 8 months is not only in clinical and research and so many things to uplift the ophthalmology in so many ways. I am really very happy. And once again, I congratulate you, Dr. Sujata. And of course, as you mentioned, ARAVIND eye care system was started 50 years back as a small eye clinic in Madurai by our founder, Dr. G. Venkataswamy. We used to call him as Chief. And in these last 50 years, now ARAVIND has become one of the largest eye care providers in the world. And all these were possible because of the clear vision and the hard work and dedication of all our founding members, Dr. V and Dr. P. N. Sir, Nachar Madam, and MS Vijay Madam, and Tulasirak, and also his entire team of ARAVIND eye hospitals. And of course, these in this not only clinical care, the patient care in the last 50 years, now ARAVIND is we are doing so many other activities like research is one of the important thing which we initiated by our Dr. PN, and also Another important thing in the last 40, 35, 40 years is the training globally, ophthalmology training globally to give a high volume, high quality and low cost surgeries through LAICO. That's also again one of the important milestones. Not only that, and also by providing cost-effective ophthalmic supplies to developing world to do quality surgery, especially IOL and other things through RLR. That's all these things done in the last 50 years. This is mainly because of the teamwork and also other dedicated work of all our staff, not only doctors, especially the paramedics and our MLOPs, all these things. So all these things were possible, how it was possible in these 50 years. So we have our own senior leaders to answer all these questions. So first talk is by Dr. our chairman, Dr. R.D. Ravindran. He is going to talk about one of the important core value of ARAVIND eye care system, that is equitable eye care, that is integrated delivery model for equitable eye care. None other than he is important person that could talk about this topic. Dr. R.D. Please. Dr. Ravi.
You can see the slides now?
Yeah. Yes.
You have to go to the slideshow mode, Ravi.
Yeah. One second. Yes? Can you see the...
இப்போ வந்து மேல display settings இருக்கு இல்லையா?
Okay, I'll check that.
அதை click பண்ணி, yeah, do that, yeah. Not duplicate, other one, anyway.
Okay. One second.
Okay, yeah.
Can you see it or...
We can see it. We can see the humble beginning.
Yeah, okay.
Yeah.
I mean, at the outset, I'd like to thank Dr. Sujata for this, for organizing this webinar and also for the good introduction. I mean, capturing almost all the important points with regard to ARAVIND. What I'm going to talk about is how ARAVIND has created an integrated delivery model for equitable eye care, which is kind of the base for ARAVIND as an organization. Like any other organization, ARAVIND had a very humble beginning to start with. We are now a 50-year-old organization. When it was started in 1976, it started as a 11-bed clinic. Dr. G. Venkateswamy being the founder president, and he was supported by 4 great ophthalmologists: Dr. Nambarmal Sami, Dr. G. Nachiyar, Dr. M. Srinivasan, and Dr. Vijay Lakshmi. They were able to take care of all the specialties. And, in a sense, they all 4 of them helped Dr. V to really set in place a very comprehensive eye care system. In addition, they were joined by Mr. G. Srinivasan, who was the brother of Dr. V, who took care of all the other logistics, including the construction of building and the finances. And Mr. Tulsiraj joined, who brought a lot of systems and processes into the organization later on. Means as a group, they were a very valuable group who really paved the success of the organization the next 50 years. So what started as a small 11-bedded clinic, today has got about 16 eye hospitals, 8 of them being tertiary care and 8 secondary care hospitals, about 9 community eye clinics and about 120 primary eye care centers, basically in Tamil Nadu and Pondicherry. And in addition to this, during this period, the last 50 years, Dr. V and the team also established the ARAVIND Medical Research Foundation, look at problems which are native to our place, like corneal ulcers and other infective diseases. And again, to make the care affordable, the oral lab was started. And the LAICO was started because to serve the purpose of the ARAVIND's vision, which is eliminating needless blindness across. And also started ARAVIND Eye Bank, and recently also organized ROI Tech. No, there is a company that is meant for production and for the software. No, as the whole eye care is becoming digital, we thought this is important. This is a new addition to Aravind Eye Care System. Was started about 2 years back. And across all these hospitals and all these organizations, nearly about 8,000 staff and trainees today work at Aravind. So this is what has happened in the last 50 years. And during this period, Aravind has been recognized by WHO as being nominating or recognizing Aravind as a collaborating center. And 3 of our founder members were recognized by the Government of India with the Batma Awards. And we also received in 2007 one of the prestigious award for eye care called Champlimad Award from Portugal. And there is a award for health, Global Health Award, probably the largest award for healthcare, which is given by the Bill Gates Foundation in the year 2008. And again, there was an award for humanitarian services. This was given by Hilton Organization in the year 2010. These were all large awards. They call them as alternate Nobel because each of these awards carry somewhere between 1.5 to 2 million US dollars. So there has been a large recognition at all levels for the Aravind's work. But I just want to share what got us here. Before I go into the integrated model, I'll just briefly share what got us here. I think one of the most important thing is the personal values of the founding team members, which is the farsightedness of them. And the second is the selfless and the compassionate work provided by each one of them. And each one of them were a role model. And not only, they had the capacity to do, but also they built the capacity of other doctors in the organization. And more importantly, their frugal and the simple lifestyle. So all of these are also not only their personal values, not only help to them in their personal life, but also in their professional life. The other important part is the vision of Dr. Venkatasamy, which he really was wedded to the idea of eliminating needless blindness, not when he started Aravind, but for the last the 30 years during his government service, he is the one who pioneered the eye care in the state of Tamil Nadu. And he wanted to do it not only eliminate blindness, but making sure that the care is delivered in a compassionate way, and the care delivered is of high quality, and also we reach everybody in the society. And the other value, I'll say that what was articulated by Dr. G. Venkatasamy, when he says that when we identify ourselves, all that is in the world, then there is no exploitation. It is ourselves we are helping. It is ourselves we are healing. This articulating these values was able to really help them to bind all the members, founding members, to dedicate themselves for the growth of the organization. And all these values, whether it is the vision of the organization or the spiritual value or the personal values, all translated into certain way of working or certain strategies, or you can say that one is the most important thing is to make eye care accessible to all. The second, the value that brought in by the founding member were the patient centricity and compassion. Third is, we have to be self-reliant for our own expansion or for our services. And the fourth being the quality and continuous improvement that allows the organization to be a self-learning organization. In addition, what also helps the organization to further their vision is the sharing of our best practices with other organizations. The frugality, not only with our own expenses, but also to make sure the patients spend less, and the staff centricity. So all these values of the personal values or the vision manifested in this kind of a value for the organization. We call them as 7 pillars, and this was articulated very well to all the staff members when it was started, about when we kind of put together these values about 7 to 8 years ago. And I'm going to talk about the first part, how do we make eye care accessible to all, which is the foundation for the integrated eye care model. The core of this vision is that we need to provide comprehensive eye care to all, regardless of the ability to pay. The second part of the vision is even more higher. It holds up a larger vision of searching out and then serving the patients who need the care. Even those patients who are not coming to the hospital or reaching us, how do we reach them? And this is in line with the principle of universal health coverage. I mean, we really wanted to make sure that the areas we serve, we are able to bring in the concept of universal eye care coverage. And this is what forms the whole model for the integrated delivery model for equitable eye care. And in order to make sure that people who come to everybody have access to the hospital, a free hospital was started in Madurai in 1978 after about 2 years later, after starting of the main paying hospital. And we also made sure that Dr. V made sure that the outpatient services served from 7:30 a.m. to 5 p.m. so that we are able to cater to all patients who need that, and that also done without any appointment, either for investigation, OP, or for surgery. All of this, help to lower the threshold for the patients accessing care in the hospital. And what we found over a period of time is that nearly only 25% of the patients coming into the hospital were seeking free care. Even though we had a free hospital, only 25% of OPD was free. And that means, the large number of people in the community who are not able to reach us, we call them as non-customers. So they are the people who will benefit, but they are not able to seek eye care for various reasons. To address this, ARAVIND started eye camps way back in 1978, 1 or 2 years after starting the main hospital. But Dr. V made sure that whatever we do in the hospital, right from having a medical record to checking the vision or intraocular pressure or a lacrimal duct passage, syringing, all that was done in the eye camp also, including evaluating for the postage segment. And a lot of importance was given for the eye camps right from the beginning. And a year or later, we found that only if you are able to provide free surgery, not only free surgery, but also free transport, free food, and free medicines. And we'll be able to, the patients will be able to come, because they were also barriers. So all of that were implemented, including a follow-up camp. So it was quite successful. And in the year, if you see about 1997, maybe since we started 20 years later, it was really contributing to about 60% of all surgeries. The camps were contributing to nearly 60% of surgeries, even though the OPD numbers were only 35%. And this, even at this point of time, Dr. V asked whether these eye camps are enough. So he asked one Professor Astrid Fletcher from UK, London School of Hygiene, to understand whether these camps are enough. Are we doing enough justice to the community? Are we reaching everyone who need care? But when Dr. Astrid did a study, we found that only 7% of those who need eye care in the rural areas were accessing the care. And this led to the thinking of setting up the primary eye care centers or creating vision centers in the year 2004. Here again, we replicated what we will do in the hospital, making sure that the quality was given importance, comprehensive eye care examination was given importance, documentation of the postage segment was given importance. So all of this, when we paid attention to the quality, these also gained the trust of the community, and we were able to see a large number of patients. Initially, we really wanted to do the telemedicine, and when the telemedicine connectivity was not available, we had put in place low-cost fiber optic connectivity, so that we are able to make sure that this happens. And we had collaborated with the University of Berkeley to make this happen at that point of time. The other important aspect that helped to really provide good care was making the quality eye care affordable. And that is where Oral Lab came into existence in the year 1992. Today, not only it is in service our area, eye care is affordable, but across the world, nearly about 10 to 12% of the patients who undergo cataract surgery today get an IOL made in Madurai or from Oral Lab. So, it was started with IOL, but later on, we found that sutures very, very important. Then we started making them. When small incision came, we made the surgical blades, and some of the important pharmaceutical products were all made by our lab, all with the idea to make the quality eye care affordable. So if you look at the integrated delivery model of ARAVIND, it is a combination of tertiary eye care hospitals, secondary care hospitals, the community outreach, and the vision centers, both of which serve the non-customers, and the oral lab, which really made the care affordable. But all of this happened only because there was a passion to serve the community in the organization from the leaders that was really made it possible. And what again, and the impact of that is kind of a universal eye coverage. We now know that after 3 to 4 years of setting up this primary eye care centers, we are able to see everybody who needs care in the community. And the eye camps really helped in identifying the non-customers in the community and also serve them. And all this, the organization growth over a period of time has happened because we had the community's faith, and which really happened because of the transparency in transaction. Our our aim of ensuring there's equity, everybody's taken care, and providing that care with empathy and compassion. All of that really helped in the community's faith, and that is what really helped in growing the volume of the patients, not just the buildings or the staff. And again, for all this expansion, we did not look at outside. Either it is funds for the infrastructure, whether it's a medical manpower or paramedical manpower or management personnel, everything. We tried to make sure that we are able to address that. We trained the required doctors, nurses, and the managers so that we had developed that capacity to support our expansion. And also, I mean, this is what this self-reliance will also help ARAVIND to grow in the coming years. And what ARAVIND Eye Care System is a journey of eliminating blindness. I think this is something that will continue, and we need to make sure that we don't lose that values as put by Dr. V. The intelligent capabilities are not enough. That must be a joy of doing something beautiful. I mean, I think adhering to that will help ARAVIND grow further in the coming years. Thank you.
Thank you, Dr. Ravidan, for highlighting the components of equitable eye care. How a common man from village comes to tertiary eye care. So, really, it's a very opener to most of the people. And another important core value of our organization is the quality and safety, not only for all, whether it's a camp patient or free patient or paying patient. It's irrespective of the way the patient comes from. This is another important thing we have to look into this, and it's one of the other important core value of our eye care system. So to do this important talk, I request Dr. Haripriya, who is head of the cataract service at ARAVIND Eye Care System, Chennai. Dr. Haripriya.
Am I audible, sir?
Yes, audible.
Not visible. Slide not visible.
Thank you, sir. And slide is not visible yet.
Yeah.
Is it seen now?
Yes, it's seen. Yeah.
Yes.
I'll be through this presentation going through ARAVIND's journey in quality and safety. So right from inception, over the last 5 decades, all our founders, this is Chief Dr. Venkateswamy doing surgery. This is PN sir and MS sir. And all the founding members have always had a focus on continuous quality improvement, which has been the DNA of ARAVIND since its inception. Through the course of my presentation, I will be focusing mainly on the safety and effectiveness of surgery, and I'll be restricting myself to the cataract examples. In terms of some aspects of where care has been improved, so under patient safety, I'll be talking on aspects such as our focus on reducing sentinel events and ophthalmitis, surgical complications, and low perforation. and improvement of visual outcome, PCO, and patient experience. In order to make patient safety clearer to our team, we came up with these 10 patient safety goals. The idea is to be able to define what we mean by patient safety. Here, goals 1 and 2 would address issues with sentinel events to ensure we identify the correct patient, implant the right power for the correct eye. Goal 3 is to prevent mortality and morbidity. And the other goals would include preventing hospital-acquired infections such as endophthalmitis and ACCO, eliminating sight-threatening complications and medical and diagnostic errors, ensuring correct medication, correct spectacles, and physical safety, and to ensure follow-up of patients who are at risk of losing vision, such as patients with macular sparing RD, etc. So having these defined goals made it easy for us to kind of take a team along with us as to how we will address it. One aspect beside having the right techniques and technology and process and protocols to ensure that we have continuous quality improvement, we also have a robust system of monitoring outcomes. So the platform which we monitor our cataract outcomes is called ARAVIND's CAT-QA, or ARAVIND's Cataract Quality Assurance Registry, which is in inception since 2008. So through this platform, one can use different filters and look at different metrics. So this is something which you can look at with the click of a button. The filters including duration, specific techniques, IOLs. You could look at a specific surgeon or a specific hospital's data in comparison to the other doctors and the best or the lowest complication. So metrics like complication rate, intra-op, post-ops, reoperations, visual outcome, both immediate and at follow-up, the late post-operative follow-up complications like cystoid macular edema, spherical equivalent, and endophthalmitis. So all of these metrics we are able to measure, and this has helped us greatly to look at how effective our treatment and our protocols have been in terms of delivering eye care. So this publication looks at data from about 1.86 million patients from 10 of the ARAVIND Eye hospitals. So if you look at the bars, the light blue bar is our complication rate in SICS in 2012 across all the ARAVIND Eye. It was about 1.3%. And over 7 years, this reduced to about 0.7. So from 2012, 1.3 to about 0.7 in 2018. And this is possible, like I said, by improving all the techniques and all the machinery and complications. Also by having regular reviews. So every week we will review our complications and see how we can improve them. And wherever we find that the complications are high, if doctors need additional training, we'll take them back to other wet labs or the simulators and then bring them back into the OR. So kind of having a supportive network, so we will keep our complication under acceptable limits. We also have this process where every week we have an hour where all the residents and fellows will share their complications. So every surgery is recorded and all the complicated cases are reviewed. The idea being that it becomes a platform for learning as to how to prevent and manage complications. So all of these efforts together has helped plateau this. Again, this is work in progress. I think as all of us know, quality is work in progress. And many of these measures also go hand in hand to understand where we are on a normal basis. The second aspect is ocular anesthesia. So ARAVIND was using retrobulbar blocks for all our SICS and some of our phaco patients, all our ocular surgery patients for almost 4 decades. I think somewhere in 2016, one specific day, one of our residents had 3 globe perforations on a single day following a retrobulbar block. And that prompted us to make a decision to move to a safer technique. So we then all moved to the subtenons anesthesia. And this was made, I think, over 2 months. So across all the 10 surgical centers, we had training of all our doctors and technicians to then perform subtenons. And this has helped us reduce the complication rates with blocks significantly. So if you can look at this table, 2013 to 16, we had about 28 block-related complications like RBH, globe perforations, and CRAO. And after we shifted to subtenons, we don't see these complications, which has made cataract surgery, ocular surgery, so much more safer after we have made this transition. The another significant improvement has been our postoperative endophthalmitis rate. So this slide shows the endophthalmitis rate over the last 15 years. So 2011 to 2025. The blue bars are the number of cataract surgeries performed, both SICS and phaco put together. And the gray line shows the endophthalmitis rate. So you can see the endophthalmitis rate has kind of plateaued after 2016. This happened because of the introduction of intracameral moxifloxacin, which happened 2014-15 across all our surgical centers. Following which the endophthalmitis rate has been lower. It reduced by about 3 or 4 times from about 8 per 10,000 to about 2 per 10,000. So over the last 10 years, ARAVIND has done about close to 35 lakh cataract surgeries, and endophthalmitis rate has been about 0.013%. In addition to our introduction of intracameral moxi, I think what is very important, which we continue to adhere to, is our focus on asepsis and sterilization protocols. We have regular infection control meetings, and we also have very stringent monitoring mechanisms in terms of documenting our protocols for CSST and asepsis from a daily, weekly, quarterly, monthly basis. Plus, we have annual audits as well. So all of this put together has helped reduce our endophthalmitis rate significantly. So moving on to some examples for effectiveness. One aspect is PCO. So almost all our free and CAM patients receive PMMA IOLs for the SICS. They used to be, we used to use the round edge PMMA IOLs initially. Dr. David Chang, when he visited us, suggested we start making square edge PMMA lenses. So AuraLab then worked on a model where we had a square posterior edge. And we had to test this model. So we went ahead and implanted this as a randomized control trial, where one eye of the patient received a square and the other eye a round edge PMMA lens. And we found over a course of about 9 years, it was a prospective study, that the patients who received a round edge PMMA lens almost always had a PCO after a couple of years. Whereas with the square edge lens, because of the inhibitory effect, there was less migration of LECs. So in the graph, we can see the PCO increasing year on year up to 9 years follow-up, whereas it plateaued after the 4th year once we started using the square edge IOL. So this is our go-to IOL for all SICS surgeries today if it is an uncomplicated SICS surgery. And the final example I would also like to share is using all of these platforms has helped us make small improvements, not just whether we want to use femtosecond platform in terms of technology, in terms of specific IOLs. So AuraLab makes this hydrophobic acrylic toric IOL called as the AuraView toric IOL. And we have made various changes. So this is a collaboration of working with the industry, using our monitoring system to understand how we can improve the care for our patients. So some of the changes include, just with this one lens, we made changes such as changes in the IOL design, suggesting new A constant, haptic design modifications, and the toric calculation platform. So when this IOL was first introduced in 2020, the IOL rotation was significant. About 29% had rotation of over 15 degrees. So this prompted us to talk to AuraLab, and then they redesigned it. So from using a C-loop haptic, they then designed a dual loop haptic design. And following observatory study using the double loop toric IOL, we found that the IOL rotation reduced significantly. It was only about 1.59% over 15 degrees. And once the follow-up was done, to our surprise, we found that the outcome was low, even in spite of this modification with the dual loop haptic, in fact, lower than what we saw with the C-loop haptic. And the reason for this was that many of these patients had a hyperopic shift. And then through their lab studies, AuraLab assessed that this was because of the design of the IOL. The C-loop haptic, the IOL was sitting in the capsular bag in the center, whereas with the double loop haptic, it was pushed more posteriorly. Therefore, the hyperopic shift. And this again prompted them to go ahead and look at a change in the design. So they then made a change in the haptic design so that the loops do not overlap, but the haptic kinds of will stretch in the capsular bag, therefore preventing a posterior push of the optic into the capsular bag. The other change which was done is to shift the A constant from 118.7 to 119.3. This also helped us improve the outcomes following toric IOL implantation. So you can see that once we made this shift in A constant, the number of patients who had less than 0.5 diopter spherical equivalent increased from 66% to about 94%. And the final shift was to have the correct toric calculation platform. So earlier we were using the Autolab toric calculating platform, which did not incorporate the PC, the posterior corneal astigmatism. But following Barrett's calculation method, they now have this also as part of their platform, and this has also improved the results. And all of this we could assess not just based on anecdotes, but actually based on the data which we had from the CAT-QA. So the first change, as you can see, improved the vision in patients beyond 6/9 from 82%. It kind of reduced it to 77% from the C loop to the dual loop because of the change in the haptic. And again, this was improved once they made the change of the haptic. And the third change was with the A constant. And finally, with the toric calculator, it improved from 88% to about 96%. So I just wanted to say that overall, this quality improvement process has been a combination of having the right processes and having the right monitoring go hand in hand. What I have not covered, and I think is very, very important, is also been on focusing on the patient experience, ensuring the patient has a good patient-centric care while they are receiving their care. And finally, as Chief mentions, I think much has been done, but much remains to be done. Thank you.
Yeah, thanks, Dr. Haripriya. I mean, it was a wonderful talk. I mean, basically, while to create that model of integrated eye care is all about the passion to serve. Here, it's all about how do we excel in the work we do? How do we bring perfection in our work? I mean, this is ARAVIND is also a kind of a learning organization. We are really focused on continuous improvement, or anyone for that matter. If you are really focused on the continuous improvement, you remain as a learning organization. There's a lot we need to do. I mean, there's a lot more we have, where we know that there's a lacuna and we have to work on that. So, thanks. I'll next call upon Dr. Usha to talk about the human resources at ARAVIND. Dr. Sujata, in case you want to make any additional comments or questions, please feel free to do it.
I wanted to ask you, sir, in the initial days, when the whole institute was started, what was the funding? Because you have started from the beginning, you were doing free service. Was there any person funding the free services, or how was it done? Because it's not a very easy task to do so many surgeries without funding.
Yeah.
So that was my...
in the initial days, when the hospital was for starting the hospital, the Dr. V and Mr. GS, all of the founding members borrowed money from the bank. Initially, I think close to about 20 lakh rupees. There's a lot of money at that time. So after paying back that, to whatever expansion happened, it all happened from the hospital resources.
Yes.
And the initial days for the eye camp, we received some grant from the RCSB, Royal Commonwealth Society for Blindness. Now it's called Sight Savers. But the amount was a small amount, not covering the whole cost. But once we introduced IOL for the patients, even from the camp or free hospital, we were charging them about 500 rupees. Okay. That is how the camps were funded. Earlier by the RCSB, later by the patients. And later on, from 97 onwards, the NPCB is funding it.
Yes.
So, yeah.
Thank you, sir.
Yeah. Yes, Dr. Usha.
Can you see the slides, sir?
Yeah, we can see the slides.
Yes.
Please go ahead. Yeah.
So good evening, and thank you for letting me take you into the human story behind what Haripriya was highlighting and Dr. Adyar was highlighting in the previous talks. We believe that sustainable excellence begins with people who show up every single day to serve at ARAVIND Eye Hospital. Let's ask a fundamental question now. before we actually deep dive into the specifics. What has kept ARAVIND alive and thriving for 5 decades? So, I would think it's the 4 pillars, the enduring mission that anchored every decision we made, the model of scalable excellence that works actually across all geographies, and human-centered culture that puts patients and staff at the heart of everything, and self-renewal, willingness to keep learning and evolving at all cadres. So, if you look at what is behind the massive operation, we have about 6,300 people across our system. About 6% are medical consultants, another 7% are fellows and residents in training. But there's this remarkable part that is over 65% of our workforce is made up of allied ophthalmic personnel. We used to call them MLOPs earlier. Now they are called AOPs. Both trained employees as well as trainees. These are the frontline staff actually who are the primary touch point for our patients. Getting the human capital strategy right for this group was not optional for us. It was mission critical. So what was the HR philosophy behind? It rested on 4 cornerstones. First was mission alignment. Every person who joins us must understand and connect with why we exist. We want people who are driven by meaning. In eye care, standing still is moving backward, so we needed continuous learning. We see our staff not as employees, but as members of a shared community with a shared purpose. This philosophy shapes everything from how we recruit, to how we train, to how we retain. So one of our most distinctive practices is that we build competence from within rather than depending on the external talent market. On the recruitment side, we prioritize value-based selection. We look for empathy first, clinical skills second. We specifically seek candidates from the rural backgrounds who mirror and understand the patient communities we serve. Our screening process is quite rigorous, with panel interviews involving senior clinicians and the HR. We hire for character and we train for competence. On the training side, we run an in-house 2-year AOP program, and these staff rotate through different postings to build cross-functional skills, and they are mentored directly by the senior members of the organization. As technology evolves, structured retraining ensures no one is left behind and everyone goes through this rigorous retraining process as well. So now the other important aspect is recruiting and training alone are not enough. Alignment must be cultivated actively. We do this through mission onboarding, ensuring that from day one, every new employee understands what ARAVIND stands for. We then create a clear link between each person's role and the larger purpose. Performance is contextualized with purpose and not metrics. Crucially, our leadership models this every day. There's something that I have learned, and most of us have learned at ARAVIND. Employee well-being is not a nice to have scenario. It's a direct driver of patient care quality. At ARAVIND, we provide housing, healthcare access, career pathways, and opportunities for spiritual wellness. We cultivate a strong community identity. People feel proud to be part of ARAVIND, and we make recognition a regular practice. When staff feel seen, they in turn help patients feel seen. What enables all of this is a structured HR pipeline, a deliberate system that ensures we're always developing the next generation of talent across all cadres, from trainee entry points to a senior leadership. Every stage of the journey is mapped, supported, and connected to the organization's long-term needs. We don't wait for gaps to appear, we plan ahead. We identify high potential staff and equip them with the tools, mindset, and exposure needed to step into leadership roles. The program usually blends clinical knowledge with management skills, interpersonal development, and exposure to Aravind's broader vision. It's our way of ensuring that the values that built Aravind are carried forward by the next generation of leaders. Innovation doesn't only come from research labs. It comes from people who are closest to the problem. Our annual hackathons bring together doctors, engineers, and technicians, mainly conducted at Aravind Eye Hospital, Pondicherry, to collaborate across disciplines and develop functional prototypes that address real challenges in eye care delivery. We also believe strongly in contributing to the global knowledge base. Write-a-thon is our initiative that brings doctors together to work with mentors and finalize manuscripts for publication. Many of our clinicians have very valuable insights, but may not have the formal support to convert those insights into published work. The Write-a-thon bridges that gap, building academic confidence, strengthening our research culture, and amplifying Aravind's voice in the international ophthalmology community. Aravind actively supports and facilitates conference participation both nationally and internationally for our medical staff. When our clinicians engage with peers, present their work, and absorb global developments, they bring that energy and knowledge back into our own system. We also create pathways for our doctors to achieve formal professional recognition, like the FICO. The Aravind Medical Research Foundation opens up a world of research opportunities for our clinical staff. Doctors can join and participate in large ongoing studies that generate evidence at scale. We also have active international collaborations with institutions outside of the country, which exposes our team to cutting-edge research methodologies and global networks. Research at Aravind is not confined to a few specialists alone. It's a culture we nurture broadly. Participation in LAICO consultancy work is a remarkable opportunity for all our staff of all categories, managers, doctors, AOPs, to serve as teachers and advisors, not just practitioners. When our team members help other institutions build capacity, they deepen their own understanding of what makes Aravind work, and they return with renewed pride and perspective. This is one of my favorites, Arangam, examples of how we democratize the intellectual participation at Aravind. It's our annual intramural conference where AOPs, our allied ophthalmic personnel, are encouraged and supported to present scientific papers and posters. Think about this, what that means to them. They're the same staff who are assisting us in the theaters, counseling, keeping patients for us. But at this moment, it transforms them and it makes them see themselves not just as a support staff, but as contributors to the science of eye care. Continuous medical education is structured and systematic at Aravind. As you can see in this screen, you see all the departments. We run department-specific CMEs throughout the year, covering everything from counseling and refraction to operation theatre practices and even vision centers. In 2025, we are marking our 50th year, and CME is part of how we celebrate. By investing further in our people's knowledge, each program is tailored to the needs of the department, and participation is actively tracked and encouraged. Career progression at ARAVIND is transparent and structured. An MLOP trainee doesn't stay a trainee forever. Through the structured evaluation, including a 360-degree feedback, they grow into MLOP employees, superintendents, supervisors, tutors, eventually clinical managers or nursing in charges. This clear pathway matters enormously. When people can see where they're going, they're more motivated to grow. And when the organization promotes from within, it reinforces the message that loyalty and commitment are recognized and rewarded. Similarly, for our doctors as well, there's a clear and aspirational career ladder. A postgraduate resident or fellow can progress to a medical consultant, then a senior medical consultant, then take on and charge responsibilities for centers or functional areas, and ultimately lead as head of the department or the head of an institution. This journey can unfold entirely within ARAVIND, and many of the most senior leaders are living proof of that. We don't lose our best people because we get them a reason and a path to stay. As ARAVIND has grown, the need for skilled management and administrative professionals have also grown. We've built deliberate pathways for non-clinical talent as well. People who bring expertise in operations, finance, communications, and strategy. ARAVIND's growth has been a multiplier of opportunity, and we have ensured that management careers within our system are as fulfilling and well structured as the clinical ones. There's a phrase I believe deeply: empowerment multiplies output. At ARAVIND, we've seen this firsthand. When employees are involved in goal setting, they take ownership rather than just following instructions. When they are included in decision making, they feel valued and exercise better judgment. When achievements are celebrated, they bring more. There isn't a management theory here. This isn't a management theory. This is just a practical driver of quality and productivity. We also recognize that our staff, our parents, caregivers, and individuals with lives outside of ARAVIND. Our childcare center ensures that parents, especially mothers, can work with peace of mind knowing that their children are safe and well cared for. The Children Education Fund provides financial support for staff to invest in their children's futures. These are just tangible, life-changing supports that deepen loyalty and reduce attrition. Beyond the statutory benefits, we also comply with all the benefits at ARAVIND. But beyond that, it offers a rich range of non-statutory welfare benefits. The Auroville provides yearly health checkups. The insurance schemes help them, give them a financial protection. The eye care benefits and the creche support families directly. And then and there are some enriching extras like the spiritual retreats, the annual Oro Utsav celebration, the annual tours, and the support for higher education. These aren't perks, they're just part of the way ARAVIND says, we see you as a whole person, not just as a role. Well-being for our AOPs goes beyond physical health. We run structured programs that address mental, emotional, and social well-being. By proactively investing in well-being, we reduce attrition, improve morale, and ultimately protect the quality of the patient care. A team that is well cannot help but do well. One of the most human things about ARAVIND is that we celebrate joy. We don't just work together, we connect. Interest groups like Wanderers, a photography and trekking club, the Melody Fridays give staff a space to bond outside the clinical roles. These informal connections are the glue of the organizational culture. When you have trekked a hill with a colleague, you work differently with them the next morning. ARAVIND conducts an annual employee satisfaction survey to understand what's working and what isn't working. We run patient satisfaction surveys that specifically monitor staff behavior and attitude. So the feedback goes in both directions. And when performance issues arise, we address them systematically, focused on the problem, not on blaming the person. This approach builds psychological safety, and when people feel safe, they perform and grow. So what are the outcomes? ARAVIND's quality is comparable to leading centers globally, as Haripriya had mentioned. Patient satisfaction is high because of the staff who are empathetic and well-trained. Care is consistent across all the facilities of ARAVIND eye care system. Staff productivity exceeds the national average for eye care. Most powerfully, this model has been replicated across new sites, proving that it is not magic, but a system. So the lessons learned, if I were to distill the 5 decades of ARAVIND's HR experiences into 5 lessons, there would be hire for mission, skills can be taught, character is harder to change. Connect role to purpose. Every person must see how their work links to restoring sight. Own your training pipeline. Don't outsource the development of your most critical asset. Well-being is an investment, not an expense. And the most important, lead by example every day. Culture is what leaders do, not what they say. I'll close with 2 quotes that I carry with me. First, ultimately, you don't find people, you build them. The talent we needed didn't always exist in the market. We created it. Second, as our founder, Dr. V, said, the power of an institution is measured not by the machinery it operates, but by the humanity it honors. At ARAVIND, we have tried imperfectly but persistently to honor that humanity every single day. Thank you very much.
Thank you, Dr. Usha. It was a really soulful talk. And we've always been wondering how you're able to motivate so many staff, because almost all our theatre staff have been trained at ARAVIND. And to keep them so motivated all the time with so much of passion is something outstanding, and really appreciate the entire ARAVIND eye care system for doing that. I mean, coming from doctors, it's very easy to be motivated because they have a goal in the end. But what about the people you take from the villages, the girls who you take from the villages, and how do you motivate them to serve so well, and how do you train them so well? Do you have a personal touch? Do you have a person who talks to them every day? Do you have a personal touch? Do you have any special secret to the success of training these people?
The answer would be, it's not, do you have a special person? Or I think everybody is empowered in a sense. We have a bit of a hierarchy where people can take up decisions. So empowering is the secret, which I think our founding members have kind of evolved in the system. And if you look at today's presentations also, I don't think any founding member is presenting. It is only the next generation and the next, probably the 3rd generation of people who are present. So empowering is what makes them completely surrender to the work that they perform. And the question that you asked about talking to them, I think we need to continuously connect with them and look at what their needs are, and equip them with whatever is necessary, not only in terms of instruments or equipments, but also mentally, physically, whatever is needed for them. And a constant touch with them is definitely essential. So people who love associating with people should be made responsible for such stuff, and I think we can take it forward.
That's the secret.
Thank you, Dr.
Yeah, in case of Vijay Madam or MS want to say something in between, no, please feel free to do it here. And also Tulsi. So. Yes, sir, Dr. R.K.
They have anything to add? Vijay Madam, Sir?
Yeah, maybe I just say something for the last question of Dr. Sujata about motivating. A couple of things which I think every one of us can do is to make sure that we give them a very enabling work environment. That is, we can completely eliminate frustration from work. They have the equipment they need, they have the space to do that, they have the skills to do it, they know whom to go if there is a problem. Like a supportive environment, that really helps. And what probably makes the most difference is make sure their boss is good. Because most people leave because of the managers. So pay attention to that level, and that also requires it's a continuous work that we have to do. So if there is no frustration and they have a supporting boss, then the motivation automatically happens.
Thank you, sir. Thank you, sir, for a wonderful and effective presentation. How good human resource from the backbone of any organization, because really when they are linked with the vision of the organization, and also ultimately to work as a team, because that's very, very important wherever they are. And also we are working as a family. That's the main important. You mentioned about the various important activities that were done by so many levels from top to bottom. Really, it's a wonderful. Thank you once again. And next, I call upon Dr. Kim, who is the head of the director of IT and also chief medical officer of ARAVIND Hospital, Madurai. He will be giving a talk on how technology fuels the ARAVIND model. He's done a lot of work in the IT for more than 15 years, and all the EMR and all these things are all the brainchild of Dr. Kim. Dr. Kim, please.
Thank you, sir, and thank you, madam, for this wonderful opportunity to share what ARAVIND does. My talk is on how technology has fostered the work of ARAVIND. So it started all way back in the 1980s when computers were not heard of. Thanks to Mr. Tulsiraj, who's the founder of technology activities at ARAVIND. When he came back from the US, he bought a 10 megabyte hard disk for $2,000 after bargaining with the Macintosh computer, and that was used for basic payroll, accounts, etc. But still, people were not believing using IT at that point of time. They were still registers were maintained, but over a period of time, it was replacing manual, clerical, or routine work. It was surprising to see when we went through Dr. V's diary way back, believe it or not, in 1988, he was looking for computer people to computerize registration, operations, ICAMS, research projects. He had a very big visionary. It was unbelievable to see he had thought of these at that point of time when computers were not heard of. And thankfully, all our leaders, the founding leadership was very strongly supportive of technology adoption at every point. I would put this in 4 different buckets, as in patient care, access to care, education, and how do we manage care with evidence. So what are the drivers for technology adoption? It is important that whatever we use is relevant. It is patient-centric. It makes the work or whatever we do efficient, ensuring quality. And in the last, return on investment. I'll tell you in the end what is the return on investment is all about. In the 1990s, we built our own hospital management system to register patients and move patients through. And this was immediately caught up by many hospitals in India, Africa, Central America, and South America, where they were started using our HMS system, which is still popular among many of those people. But how did we use it? You all know that ARAVIND doesn't have an appointment system for any new patients, or any patient is a walk-in patient. But how do we manage when, especially in Madurai, we get about 2,000 to 3,000 patients every single day? How do we plan our resources by predicting these patient volumes over a period of time So we know exactly how many patients are going to come that particular day based on holidays, per government holidays or public functions. We know the numbers will go. So accordingly, the resources are kept ready. And this has really helped by creating this calendar for the entire period and clinical management system. So at every clinic, we have a live data coming in that shows how many patients are being seen in each of these clinics and how long. Like, are patients waiting for more than 2 hours? So immediately that gives an alert for the managers to act upon it, to understand why patients are waiting. So this is an ongoing activity that is happening thanks to technology. And in ARAVIND, it is very important that we, complete the patient's investigations as much as possible on the same day. This is mainly to reduce travel time and cost for the patient. Of course, for many, it's a loss of daily wages if the patient has to come again. Physical strain, especially for elderly and visually impaired patients, and reduces not only for the patient, but it is also importantly reduces the administrative overhead for the institution. I don't know, many of us don't see that, but that's what happens when you ensure that the patients are seen on the same day. And recently, we have been looking at how it reduces carbon emission when you avoid multiple visits by the patient to the hospital. When I say staying relevant, it is important that you are up to date with technology, what is happening in this thing. When IOLs came, we were one of the, thanks to Dr. V's vision, we were ready to move in, not only do the surgery, but also make these lenses. And more importantly, Dr. Nachir, Jane Madam made the first IOL microsurgery training, which really paved way for many of the practicing ophthalmologists to start doing IOL surgery. Of course, we have subsequently many starting on phaco, adopting new devices. We were already there. Like, we were first to get many of these equipments like femto cataract surgery, LASIK, and many of those. Then in 2014-15, we were looking of starting electronic medical records since 2010, but we realized what's available commercially is not, will not work for ARAVIND. So we started again in-house development of EMR, what we call as iNotes, mainly designed not just like it is not just one more data entry screen, but we wanted to ensure standardization. Can it generate actionable insights to how we take care of patients and improving patient interactions? This is one example. In our primary care centers, we ensure that every patient gets their, especially the diabetic patients, the fundus photos are taken so that the doctors are able to see the retina. So this is a mandatory alert that comes from the EMR. And similarly, many alerts like this come. Dr. Haripriya elaborated on the importance of CAT-QA, which plays a major role today in how we are maintaining our quality of our cataract surgeries. We are now building on other surgeries like retina and glaucoma. And the second bucket, access to care. ARAVIND is known for the eye camps that we do almost throughout the state. How do we use technology? We have been trying to use the geographical information system to study the distribution of people in various villages so that we are able to place camps in those areas where the camp productivity is that much improved. And over a period of time, when we studied using this GIS system, our productivity in these camps went up by 35%. Today, we are experimenting with using electronic medical records in the outreach. It's still a work in progress. In the early 2001, when ISRO gave us the satellite connectivity, we were able to, like Shankar Netralaya also tried this, we bought a mobile bus, which will go into the community, screen diabetic patients for diabetic retinopathy. And this we continue till today. Since 2003, we have put multiple fundus cameras in many diabetic clinics across the state, where the technician takes the pictures, will send it to us. Our ophthalmologist used to read these images, generate a report, and send it back. And this continues even today. From 2004, we realized, as Dr. Ravindran mentioned, about the utilities in the camps. We moved to the vision centers, where we started doing teleconsultation using a trained ophthalmic technician. Technology at that point of time was very poor. We used extended Wi-Fi given by Berkeley, University of Berkeley. And then once internet came, we moved to the broadband. And those days, we put up these antennas that you see today to keep a line of sight between these vision centers and the base hospitals. So it has been scaled not only in Tamil Nadu, but in many states of Tripura, Chhattisgarh, and Bangladesh today has opened almost 290 vision centers with a similar model. In academics, technology today plays a major role, not only today, way back in 2002 when video conferencing came in. At that time, there was no Zoom, no Google Meet. We had to buy these expensive Polycom video conferencing equipments, which were like 4 to 5 lakhs each. In each hospital, we would place this equipments and used it for patient consultation between hospitals. And then for teaching, even at that point of time, we had a lot of grand rounds that were happening, not only between Arvind, but also with, Arvind Wilmer. We had a regular grand rounds once in 3 months. You can see Dr. Martin Goldberg here talking to us from, so we would present cases, they would present cases. It was a wonderful time at that point of time. Recently, we have also put this Loop to Learn, which is a learning module for doctors in our electronic medical record. Any junior doctor sees a rare case, he could put the question to the doctor, senior doctor who's going to see this patient on his doubts. And the senior doctor who sees this case can enter it just like in an email, which is part of the EMR, but not in the part of the case sheet. It's a standalone thing that will be moving with the patient cases, so doctors can ask questions and others can answer. So this is a wonderful learning tool that the doctors can use, the junior doctors are today using, which we call as Loop to Learn. DigiNerve, again, the popularity of this DigiNerve and flipped class, which Dr. Prajna initiated and running it very successfully. There are already more than 6,000 subscriptions, one of the highest used application, we believe, that is being used by most of the postgraduates across the country. Then 2020, we see the era of AI, where that we started working with Google. Myself and Dr. Rajiv Raman from Shankar Nethralaya, we worked and developed a algorithm that would automatically grade diabetic patients. So today we have replaced this. For the last 6 years, the AI tool is grading, the diabetic retina patients, not only in our diabetic clinics, but also in our vision centers. And we saw post-AI, the diagnosis of DR went up almost 8 times. Recently, we have screened a little more than 1 million diabetic patients for diabetic retinopathy. So in this process, we also realized we need to have a separate division. So in 2022, we started Oro iTech, which Dr. Ravindran mentioned, which was mainly to support the IT need for Arvind and how to improve eye care using not only iNotes, but many other digital applications that would help in improving patient care. So today our iNotes is not just a documenting application, but it also brings in some standardized protocols, patient safety, develops. We are trying to build in a lot of AI tools to bring a lot of insights into patients' outcomes and making it easy to use by speech to text extra. I was talking about return on investment. The return on investment here is not in terms of money, but it is on the impact that every single activity or initiation that we have been taking, such as how much of effort or outcome it is creating to the patient care that Arvind is involved in. So innovating in digital health is always towards a purpose around specific problems with real use case scenarios, and that has made the use of technology that much more meaningful, and the outcomes are much better. And there's still a long way to go with, especially with the AI and all these ahead. We really have an exciting time ahead that we can use in delivery or improving our patient outcomes. Thank you again for this opportunity to share about technology at Arvind.
Amazing talk. Excellent talk, sir.
Thank you, madam.
More to add, I think it's really a 360-degree coverage of all the technology that has been used. And I was just thinking about AI, and I think you finished off with it.
Yeah.
I mean, yeah, thanks, Kim, for a wonderful talk and covering, everything. But doing it in 15 minutes, it's not easy. And thanks for the good presentation. And we move on to the next one, which is the work done by LAICO, which is basically, how do we share our best practices of ARAVIND with organizations outside of ARAVIND. So today, LAICO works with nearly 400 eye hospitals in India, in South Asia, and also Africa and South America in a large way. Maybe not only we share it, but we are also emotionally really involved with those hospitals as our own hospitals to see how they really do well. I'll request Divya to give an overview about the work of LAICO. Yeah.
Thank you, sir. I'm happy to share about LAICO's work. Just to step back a bit, so all of this started really even from the very early years of ARAVIND. What started as like an organic response to different requests that came in from other eye care programs and eye hospitals. For example, Nepal did not have a formal ophthalmic assistance structure, and the first batch of ophthalmic assistants, Dr. V was asked to train. So as early as 1981, when ARAVIND did not even have a fully functional training program, even then they were able to really put together an excellent program for training these ophthalmic assistants. And Dr. V went on to also be part of developing the curriculum for this cadre for Nepal. Similarly, WHO reached out to ARAVIND in the mid-80s to really help address the cataract backlog in the country. So several teams over 3 years went to Maldives and conducted surgical outreach and were able to do a high volume of cases and really deal with the problem in Maldives, mainly because there was no ophthalmologist there. The one ophthalmologist who was there was also on in an administrative posting. So really the country was suffering. So similarly, several such requests were made in the early years to ARAVIND. And I think this really got the leadership team then thinking, because the burden of blindness and visual impairment is so large. And somehow through the many reasons that you heard in the previous talks, ARAVIND seemed to have a successful model for eye care delivery, which also was addressing the need in the community, a good business model, but also was addressing the need. So the thought was, can we do what we're doing, but can we share this in a structured way to help other eye hospitals succeed? Because it's very important for the entire eye care fraternity to succeed, for us to really address the problem of blindness. And that is what really gave birth to this idea of the Alliance ARAVIND Institute of Community Ophthalmology to provide this kind of support for eye care programs worldwide in a very structured way. And LAICO does this by providing services at 3 levels. First, by training the individual eye care professional in whatever cadre, building their capability through training. Second, to really transform institutions through consultancy, and to influence policy also through research and advocacy. So first, starting with training, LAICO has really, while a lot of clinical training is offered at ARAVIND, and many of you may be aware of that, more importantly for LAICO is to really address and strengthen the management capability of the hospitals, because this is really important for hospitals to succeed. Clinical excellence is important, but you also need to have operational excellence. And this is where LAICO's training programs come in, where we look at different cadres of management within an eye hospital. It would be the eye hospital leaders. We train the administration, the administrators and managers. We also have a 1-year fellowship training program through which our own managers are trained, but we also train other managers for other hospitals. We also train camp coordinators or managers to help them conduct successful camps. And also, because we work with many NGO hospitals that receive funding to do eye care projects, we also find that sometimes they kind of don't have the capability of conducting a camp very well in a satisfactory way for the funds that they receive. So this project managers course is one of our popular courses that also helps these hospitals to successfully implement a program, but also ensure that whatever they are doing in a funded project sustains beyond the funding as well. So these are some of the training programs that we offer. The consultancy program that I spoke about is where we work with client hospitals, which starts with a needs assessment, where our team would go to these hospitals and really understand on ground what are the gaps and what are the strengths of this hospital. And then we have a multidisciplinary team that comes from the hospital to Madurai, to LAICO, and we would take them to an appropriate ARAVIND hospital. It could be, if it's a smaller hospital we're working with, we would take them to our secondary center, for example. And they get to see what happens at ARAVIND, the systems and processes. But very importantly, they also sit and develop a vision and a strategic plan that is relevant for their own context. So they come up with these action plans, and we work with them for over about 2 years by providing mainly monitoring, ensuring that they are staying on track with this growth plan. But wherever necessary, we have teams go into these hospitals and provide on-site support. You'll see that, as Dr. Usha mentioned earlier, we have our staff who would spend, for example, a month. Say this is a sister who spent a month in Zambia trying to improve their outpatient processes, really strengthen the quality and the efficiency of the process. And another important aspect of this is a couple of times during this journey, we would bring in the cohort of hospitals. So it's not just us telling them or teaching them. It's not really teaching, but more about peer learning. And these review meetings that we have typically in one of the client hospitals usually hosts this. We have similar hospitals coming together and sharing their data. And this is a very powerful exercise, we find, because these hospitals are able to see how their performance stacks up against their own peers. And we find a lot of good practices being shared across these hospitals. And it's usually a very fulfilling experience to be here. So the impact of this consultancy, we've seen that over 2 years, we see some of these hospitals doubling their volumes, anywhere between 30% to 100% growth in the number of surgeries that they do. And very importantly, we also see, because many of these are NGO hospitals whose performance is very linked to the kind of funding that they receive, through improving their walk-in patients, through improving their quality, becoming more attractive to the paying clientele. We're also, and also through efficiency and cost control, we're also able to help these hospitals become more financially self-sustainable, so that their performance is not really linked to the funding that's available. And through this, we're able to really transform the performance of the hospitals. And this is not so much a problem in Tamil Nadu, but in almost all other parts of India, we see that these hospitals are severely underutilized during the summer season. Most surgeries happen in the peak period in the 4 months of the winter. And you'll see 85% of these surgeries are done in those 4 months, and the rest of the year, very little is being done. Through working with them, through really helping them believe that they can do safe surgery, they can do high volume surgery in the summer, we see that not only has the numbers grown over the years, but significant shift in the utilization of their services across both seasons. So this hospital, for example, is now doing 45% in the 4 months. So it's more evenly spread out their volumes, and you can see how this is much better for the hospital as a whole. We also work with hospitals on it may not be about bringing more cases, but from the cases that they're already seeing, critically examining these processes to see, are we missing out surgeries? So this is a set of hospitals, a cohort of hospitals we worked with, where we help them really examine, are all the cases all the patients you see of whoever is eligible for cataract, are they first advised cataract? And of all those advised, do all of them actually reach a counselor? We found in many of these hospitals, there's a big leakage even from advising from the doctor's table to the counselor's table. And then furthermore, as you know, patients also who are counseled, do they actually undergo surgery? If not, do we address the reasons why the patients drop out? So through working with the cohort of hospitals, I'm just showing you an example of the hospital that we worked with, in fact, in Tamil Nadu. You can see that in the year when we were working with them, the outpatient numbers did not grow well. But they really worked hard to plug all these leakages. And within just 1 year, they were able to see an increase of about 27% in the cataract surgery. These are all paying cases, not camp cases. These are all paying patients. And you can see the amount of, and you can imagine the amount of revenue that they were missing because of this leakage earlier, and how that, this yield is so important for all of us. So in this way, we've worked with over 400 hospitals across 29 countries, several of them in the developing region. And we estimate that through this work, we're probably adding 1 million additional surgeries every year through these hospitals' growth. And we also try to help hospitals to have access to best practices through other means, by through our resources. We also do it through specialized training. So one of the things that we really think is very important is having a good instrument maintenance team. So in fact, one of the things that we've been really promoting is the instrument maintenance training. And this training has gone literally all over the world. In fact, the team came back just last week from Papua New Guinea, where they conducted two workshops. Really helps the hospital to save money, really helps the hospital to become much more efficient, because this equipment are capital resources, so expensive. So how can you get the most out of them? In fact, we're very proud of our instrument maintenance team. In fact, and it's a running joke here, how the slit lamps or the microscopes at ARAVIND have been here for decades. So our depreciation really is really, you'll see, is very, very low, and is really thanks to this team. But we also want to ensure that this training or this cadre is available for across the globe. So every other month at ARAVIND, we have this course, and we train people from Africa, from Bangladesh, from several parts of the world, so that they will go back and also make their own hospitals and countries more cost effective. We already heard from Dr. Kim about the vision centers. We're very convinced that vision centers play a big role in really providing coverage for eye care and really ensuring universal eye health. And we are proactively telling governments, we're proactively telling eye hospital leaders how this is such a powerful mechanism to reach the people and also build your own volumes. So related to vision centers, we offer consultancy, we offer training, both for managers as well as for the vision technicians who actually man these vision centers. The last segment is really about one of the things that we always see is this ophthalmic assistance, or what WHO calls the allied ophthalmic personnel in eye hospitals, form a really critical role. They can really help improve efficiency. They can really help improve quality. In fact, at ARAVIND, as you've heard several times in today's talks, our AOP really form the backbone of ARAVIND. And in order to ensure that other hospitals also have the benefit of a well-trained allied workforce, we've put up online a free a library of our training, whatever we use for training. We've just put that online through this website called AuroSiksha. So hospitals are able to access slides, assessments, skill assessments that we use. And if some of you are on Facebook or LinkedIn or even on WhatsApp, you can subscribe to the AuroSiksha page, and you'll have your AOP will have access to continuous learning resources. For example, this is our most recent quiz on ocular emergencies. We're also putting out, every month a webinar on topics related to AOP, because this is one of the cadres that don't have access to good training material. Every week we put out like a small, just something to learn in just a minute, how they can constantly be retrained on things that they may have learned during training. This helps to retrain them. We put out what is called a Siksha Bite every week. So this really has been to tell you the different aspects of what LAICO does. Thank you so much for this opportunity.
Fantastic talk, madam. Really, it's an eye opener for us. Really appreciate what all you shared with us.
Thank you.
Thank you, Dr. Divya, for a wonderful presentation by saying what are all the ways by which LAICO is doing globally to make eye care efficient, and also to escalate what are the new things happening in the field of ophthalmology. Thank you very much. Because of want of time, we have to rush, and next to talk is by Dr. Ratnam, how research contributing to advanced eye care, and also what ARAVIND's contribution in research. Dr. Ratnam, please.
Ratnam, you are muted. Ratnam, you have to unmute yourself.
Good evening, everyone. I am very happy to talk about advancing eye care through research and ARAVIND contribution over 50 years. And believe it is in spite of such a high volume of patients, ARAVIND has published nearly 3,700 papers, 3,700 papers in 50 years. And obviously, you all talk on every contribution of this, but you will know that probably 100 publications are really path-breaking, but I'm going to talk only important things. The slides are not moving. Can you help?
Use a mouse or use a keypad. Try one of them.
Yeah. Is it visible now?
Yeah, now we can see it. Now we can.
So I'm going to talk only path-breaking research in ARAVIND. And that included clinical research, epidemiological research, basic research, and operational research. And every time the researchers were not moving on same line, they made a deviation to find out something really, really interesting. And that helped not only India, it helped all over the world. The first one I want to talk about is the one which you are totally we know, and that is part and parcel of our life. So we don't even think that it is innovation. We think that it is way of life, but this is also innovation. A high volume, low cost, high quality cataract surgery model is a first innovation made by Dr. Venkataswamy sir, and it is taught in Harvard case studies, and it became global template for affordable healthcare delivery as well. And this is the true path-making research to start with 50 years back. Then comes the vitamin A supplementation study, and several major studies have been taken place 45 years back, and it were published in a very big journal like a National Journal of NEGM as early as 1990. And they proved that the child mortality is much less, and it is reduced with vitamin A supplementation, and also it prevented blindness. And many of you know, when many of you might have seen, RDR sir might have seen, when we were students, there are at least 4 to 5 patients going for perforation of keratomalacia. Now we don't even see single case. And all these things are better research and implementation of better nutrition and supplements. And this is also one of the very important study. And designing for non-customer, already previous speakers have spoken about this. Barrier to uptake study. This is about, even though we are giving free service, the patients are not utilizing that because of lack of awareness or economic concerns or social and cultural barriers, fear of surgery, fear of meeting doctors. So Aravind found out this iCamp model, which was published in 1991 until 2002. There are fantastic papers, and this outreach iCamp model is replicated globally, adapted across India, Africa, Southeast Asia, and they are really successful. And massive increase of cataract surgery has taken place after this outreach camps. Then comes Aravind Comprehensive Eye Survey. I am very, very proud of this comprehensive eye survey, because it is a large population-based eye disease survey conducted in Tamil Nadu, covering both urban and rural population. They really measured the visual acuity, they did refraction, they looked for cataract, glaucoma, retinal and uveal diseases, bringing the deceased patients to the base hospital. So we had India-specific data available. All these years we were using the Western data, extrapolating them. But we are so proud to have India-specific data, and also from focus mainly on cataract, we started focusing on multi-disease approach. And originally it was passive care, just removing the cataract. It became targeted community strategies. So it told us that even people need glasses, remain blind. So we were able to address the refractive powers also. So the previous study, the Comprehensive Research Survey is fantastic study. And then comes the Madurai Intraocular IOL Surgery, MIOL study. This study is the most important study, which told us that IOL is feasible in high volume setting and lower socioeconomic group, and it changed the cataract paradigm in developing countries. This is a wonderful study, because otherwise many of our Indian might have been fake even now. So my MIOL study is a fantastic study to bring the IOL to India. Then comes the low-cost intraocular innovation, and the RO Lab reduced the cost from $100 to $5. And now it exports to 160 countries. And that this particular program made the modern cataract surgery even to the lower socioeconomic group. I am 100% sure if a beggar is sitting in front of a temple, has a green screen in front of his eyes, you just elevate the screen, he will have IOL. So that much it has become so popular. And research on rubella, again, we have to appreciate the investigators so much, because it is the first study of its kind in eye hospital worldwide. And it led to vaccination programs, and rubella cases in India declined significantly. And the hospital began linking neonatologists, pediatricians, and ophthalmologists. It led to team-based newborn care. And many children are alive now, and because of the proper vaccination, and many children are seeing now because the rubella blindness is reduced drastically. Then comes the ROP, retinopathy prematurity, retinopathy of prematurity program. And this is the first in India to introduce RETCAM imaging and using anti-VEGF therapy for ROP. And here again, the team-based newborn care has evolved. This is also path-breaking research. Then comes AI and teleophthalmology. You might have heard from Dr. Kim, and this made really a revolution in screening diabetic retinopathy in rural areas. And a massive scale of screening is happening in a cost-effective model, and it created policies and guideline influences. One of his publication received 4,000 citations. So such an important field. Then comes the retinoblastoma translational research. They worked on RB1 gene screening, which they are able to give it for 1,500 rupees, but in abroad it is $1,500. So this test has become possible for everyone. So we can predict the prediction analysis can happen, and we can see whether the siblings will develop retinoblastoma or not. If a first child has retinoblastoma, when mother is pregnant again, with the amniotic fluid analysis, we can say whether the child will have retinoblastoma or not. And the research on retinoblastoma has gone way beyond imagination. And the traumatode granuloma in children, usually these granulomas were thought as tuberculosis because they are millet-shaped and looking like tuberculomas. But Aravind proved that it is a traumatode granuloma. Like schistosomiasis, it is a traumatode granuloma. It published an article on histopathology as well as molecular diagnostics. The disease is not only seen in India, it has global implication. It is seen in Egypt and Brazil as well. And then comes the APEX study, the pseudo-exfoliation study, which is a very large study, which told us that there is a risk stratification in pseudo-exfoliation cataract surgery. CTR is not always needed, and we can have an evidence-based IOL selection. This is one of the largest study. And MUT study, again a path-breaking study, because it supported the cheaper natamycin, which is superior to voriconazole, which is extremely costly. And it works especially effective in fusarium and other filamentous fungal keratitis. And SCUT study talks about the role of steroids in bacterial corneal ulcer. When it is used with care, it is definitely useful. And intracameral moxifloxacin, already Haripriya has addressed. It changed the practice pattern worldwide, and incidence of endophthalmitis has come down drastically. And there was another study where methotrexate, which is very cheap immunomodulator, is compared with mycophenolate mofetil, and the study proved that methotrexate is more efficacious than mycophenolate mofetil in treating uveitis. This is a NIH-funded study. Then ROLab aqueous drainage implant, which is cheaper, and this is helping most of our intractable glaucoma in poor socioeconomic group people. This is also a path-breaking step. So first 20 years, Aravind was looking at doing research and community research and operational research over the community research, Whereas the next 20 years, it added the clinical research as well as basic research in addition to community research. Then the last 10 years, there is quite a lot of translation research in addition to already existing research. There are so many things to discuss, but time is very limited. So I am closing here, and we have so many programs going on. Let us have different talk at different time. Thank you. Thank you for the opportunity.
Thank you, ma'am. Thank you, ma'am.
Thanks, Dr. Ratana, for trying to put together all the research done in Aravind in 10 minutes time. I think we move on to the last presentation by Dr. Aravind, Dr. Karthik, and Dr. Venkatesh on what are the future directions for Aravind. Dr. Aravind.
Yeah, I think Dr. Ratnam, madam has to remove that presentation. She has to.
You have to stop sharing.
Yes.
Escape, escape, stop sharing. So,
Yeah.
Yeah. Are you able to see the slides?
Not yet. Yeah. Now we can see it. Yeah.
Yeah. Good morning, everyone. Sorry, good evening, everyone. I'm going to be speaking about the future of ARAVIND very briefly. So this is how ARAVIND has evolved. All of us have spoken about it in one way or the other over the last 50 years. Each phase has contributed something significant. Like the first phase was more coming into existence, which is the first 10 years. A lot of struggle. The question Dr. Sujata Mohan asked about how it was funded and all that. The second phase was a very vibrant phase where Orolab, LAICO, AMRF, all of that came, and also a seed of the first vision center. And the third decade, again, a lot more effort on research, secondary hospitals. We also had city centers and secondary centers started. And 2017 till date, we have opened hospitals in Chennai, Tirupati, Tanjavur. So quite a few of these newer projects have come. These are all physical projects, and each one of us have spoken about the different projects that we are all doing. What's happening, interestingly, is India is going through a massive transition, to 1970 India to 2026 India. When ARAVIND was founded, India was a young country with 29 post-independence of 29 years. Life expectancy was only 48 years. GDP was 67 billion. Tamil Nadu's GDP is larger than that now. India GDP falls below zero in 1979, severe drought, global oil crisis. So we came into existence at a GNP of $140. But 2026 is very different. We are the world's fastest growing economy. Our life expectancy is about a little more than 70 years. GDP is 4.1 trillion. And rapid expansion in manufacturing and exports, growth in green energy, increasing global economic influence. So I think it is but for true that the next 25 years is going to be very fascinating for this country, for all of us as ophthalmologists, for all of us as care givers. So how are we going to leverage that? How can ARAVIND leverage this whole transition is something that we are thinking upon. So broadly, ARAVIND, the primary aim of ARAVIND is clinical care. That is what we exist for. It's about eliminating needless blindness. And it's powered by both research, innovation, and academics and training. And Dr. Venkatesh will be speaking about innovation. And Dr. Karthik will be speaking about the AI developments that are enabling ARAVIND and ARAVIND-like organizations to do and reach people better. So future of AECS as far as infrastructure, I think infrastructure is a very critical element for all the growth because ARAVIND works on a large scale format of eye care. So how do we move from high volume excellence, more focused on efficiency alone to globally benchmarked care environments? Care environment is very different than just driving the number of people. So that's what that describes. So establish more intelligence in hospitals and patient-centric and staff-centric design, and also bring in a lot more green and sustainable facilities. Even now, close to 80% of power that ARAVIND draws is from green sources, from its own rooftop solar and also from wind and other solar farms. And also try to achieve leadership, technology leadership. Dr. Kim covered part of it, and part of it is also in the ophthalmic technology, the equipments, the newer technologies that comes because the scale of work, it needs to be done with precision and it has to be done consistently over a period of time. And also, I think Dr. Usha spoke about the HR practices, I think, which will have a significant change, from where we are at $4,000 per capita going to $15,000, $20,000 per capita. I think HR is going to be a very crucial element for us to scale in the future. So some of you would have seen some of these new projects. So the design language is very different from ARAVIND Hospital. The past design language of ARAVIND, it has evolved over the decades. So now we are trying to become more contemporary and also trying to make facilities more comfortable, appealing for both the patients and the staff members. And some of the, I think in the last 5 years, we have built close to 2 million square foot of space for eye care in different places, ARAVIND eye care system. So this is our training facility. I think a lot more importance is going into training facility. So each hospital, like the new Madurai hospital, has close to about 50,000 square foot for training facility. So these are, Chennai has about 7,500. So large focus, large areas are dedicated to training with the simulation and all the newer modalities of training. So hopefully it will be a added benefit to the young ophthalmologists who come in through the system and to the country. So finally, it's a very exciting period, next 2 decades for all of us as ophthalmologists. I think ARAVIND has had a very proud past and an active present. And as a country, we have an ambitious future. I think not only for ARAVIND, I think all of us have to buckle up and be ready to handle this future. Thank you for the opportunity. Request Dr. Venkatesh, Karthik, one of you to please take over. Yeah. Thank you.
Thank you, Arvind. I'll just go next. Yeah. So the next few minutes, I'll share how we are nurturing innovation at ARAVIND. We just saw how we have built a very strong value system through which we have been doing good eye care delivery, not only in this part, but across the globe. But what stands as something which is a foundation is some of the innovations which we have been doing over the years. So there has been kind of most impactful innovations, and most of them have been system innovations in the past, like how from eye hospitals we wanted to reach people through eye camps, vision centers, even operating on twin tables in OR, now developing a new cadre of people called the allied ophthalmic personnel in assisting us. So by doing all these innovations, it always kept us in the forefront of whatever we were doing in eye care. And over a period, we realized that we have to move on from system innovations to systems and beyond systems into tools and techniques. And that's when we created an organization called ARAVIND Center for Eye Care Innovation way back in 2018. And it was kind of to kind of create a structured ecosystem for people who wanted to innovate within ARAVIND. And this got momentum during the COVID time. When we had lockdowns, we had a lot of time to improvise on some of these ideas and come up with workable prototypes. And this particular statement, which I always recollect, is never let a good crisis go to waste. And that's a time when we really worked on a lot of these hackathons to bring in a lot of these ideas into practice. So the ARAVIND Center for Eye Care Innovation came up with a vision to ensure ARAVIND Eye Care System continuously innovates to enhance its work and eye care in general to eliminate needless blindness. So these are the 5 ways ARAVIND builds a culture of innovation. We always keep the doors open for problems, and also if they come up with some ideas, either it may be from the doctors, paramedic, managers, or whoever is involved in eye care in our facility, we always keep the doors open. We kind of empower the staff to think over that. And we also now give time and support to improvise some of these ideas. And we also understand that failing is okay. And if we fail, we also fail very quickly and then we move on. And once we find something is successful, we also keep track of it. And we also kind of share within the ARAVIND system and also across eye care, depending upon how that innovation can benefit people around us. So from incidental innovation, now we are going to kind of intentional innovation. So we have a central platform, which is the ASI platform, which kind of coordinates, supports, and also connects the innovation efforts. And now we organize regular hackathons. We do almost yearly hackathons now in Pondicherry and in few other places, including Tirupati and few other hospitals we have started, wherein we engage engineering institutions, namely Vellore Institute of Technology, IIT in Tirupati. And these young engineers work with our doctors, and they collaborate even with other partner organizations like AuroLab, Remedio, Appasamy, and few other organizations, and they come up with brilliant prototypes. And some of these prototypes, we try to take it to the next level quickly with the help of our Ideas Lab. And now we have one Ideas Lab at Madurai, but we tend to have Ideas Lab in all our tertiary care centers. So these are our partnering organizations for the regular hackathons, which we conduct at Pondicherry now during the first week of January. So the Ideas Lab was created last year in Madurai. Seeing all these brilliant ideas coming up in hackathons, we wanted a separate lab wherein we can do a little bit of redesigning and redesigning and better prototyping. We have an excellent facility now for a team to brainstorm, and we have different type of 3D printers and experts who can do CAD drawings and who can help the doctors to kind of design their prototypes and modify their prototypes quickly to the next level. And we have a couple of engineers to help them who have the background of biomedical engineering. And this is the Ideas Lab, which you see at Madurai. And now we are trying to have similar Ideas Lab across all our tertiary care centers. And recently we have instituted a committee called an IPR committee. And we had the first meeting today, basically to review some of these prototypes and ideas which have come, some innovations which have come, how to take it forward to the next level, how to support them in patenting and other processes. And also we have, for the last 5-6 years, an ARAVIND Inspiring Innovator Award, where people compete within ARAVIND, bringing some of their innovations, in the form of short videos, and they are being awarded every year. And many of the products now, our sister concern AuroLab is helping us to kind of develop into products and also in commercializing. Especially recently, their new phaco machine have one of our ideas into practice, which is called the saline load sensor. And some of them which we can't patent and which is but a very good idea, we share immediately in conferences and also using some of the platforms like social media, and also we publish some of the articles in IJ and other reputed journals. So this is what we are looking way forward in the next few years, setting up Ideas Lab, strengthening the committee and reviewing some of these ideas and supporting them, and also to build other institutional collaborations. Recently, we collaborated with a program called Center for Bioengineering Innovation and Design at Johns Hopkins University, and we are trying to develop some low-cost solutions for low-middle income countries. And in the future, to increase the patents, products, and also to look at process innovations. So this is how I think we would still stay relevant in the future years to come. Thank you.
Just Karthik.
Yes, sir.
Yeah. I mean, this innovation which Dr. Venkatesh presented is also about developing a culture in the organization. Usually we try to bypass all the problems, but when you have that mindset, when you have the culture of innovation, then people will look at problems in a very different way. So otherwise, they'll try to find a way out of the problem, go around that problem, but now they try to see how it can be resolved. So that's a huge difference in the mindset, and to have people developed in that mindset will be a very strength to any organization. Yeah. Yes, Karthik, go ahead.
Thank you, sir. So I'll just give you a brief on AI in ophthalmology that we have going on in ARAVIND and what the future holds. So from this slide, you can see that the people have built temples which have stood centuries together. But we now see that we have built code that reinvents itself overnight. So that is the age that we live in, and we have to adjust to what comes next. So let's ground ourselves in what already exists. This isn't science fiction. These are deployed real-world tools like what Dr. Kim had already told you about. Diabetic retinopathy, we already have tools like ARDA, which are primarily used for primary care screening and not just in specialist centers. It's a paradigm shift in screening reach, where every patient who has diabetes is screened directly and a report is sent directly to them. Glaucoma detection by Dr. Venkatesh and team from Pondicherry, they have developed deep learning models and are now matching fellowship-trained specialists in optic disc analysis and OCT interpretation. The question is no longer can AI do this, but how do we deploy it responsibly? Workflow and triage, like what Dr. Prajna sir has customized in cornea department in Madurai, is not just beyond diagnosis, it is quietly transforming how patients move through systems like auto-grading, priority flags, intelligent routing. These are already cutting waiting times significantly. So if you look at surgical AI, a field that is picking up slowly nowadays, these research papers focus more on intraoperative pupil analysis during cataract surgery. They use video frames from operating microscopes, AI models that can segment the pupil in real time, detect obstructions, and track pupil behavior throughout the procedure. Why does this matter? Because this opens doors for objective surgical training assessment, moving beyond subjective feedback to quantifiable performance data. Something related to drug synergistic activities, we call this systems biology using computational methods. So this is a fascinating application of AI that goes beyond imaging. Using transfer learning, we are predicting drug synergy for pathogens causing eye infections, in this case for Pseudomonas aeruginosa, like what we are showing. So our most common combination that we use of moxifloxacin and gatifloxacin, does it even make it to the top 20 according to the computer algorithm? So then we went ahead with Dr. Lalita and team from ARAVIND Madurai to check what had the most synergistic activity. And we found ceftazidime and tobramycin to have better synergistic activity against Pseudomonas rather than gatifloxacin and moxifloxacin, which we proved that the computational model was right in the lab. So what are we building at ARAVIND now? So we're trying to build what we call as Center for Ophthalmology Data Analytics. Our goal is to transform our clinical data into fair data sets, whereby we connect with centers globally using large language power models or agents to help our clinicians with literature review, idea generation, manuscript writing, and embedding AI tools directly into clinical workflows for smart routing and AI-assisted diagnosis. So what does this actually mean? We are trying to form a tool which helps each and every researcher at ARAVIND to have a pipeline that he's trying to build using these 5 stages. The stage 1 is your idea and novelty check. A clinician has an observation. Instead of spending weeks searching through PubMed manually, a large language model connected to a semantic scholar can tell them within minutes, has this been done and what's the gap? The second is to try an experiment design, where templates and code agents help structure the study design, suggest statistical approaches, and flag potential confounders. Then we automate pipelines, extract, clean, and analyze data from clinical systems that are fair in nature. No more weekends lost on spreadsheets. Then you have a manuscript draft that the agent produces as a structured first draft that you can clinically review using a clinical judgment. But the blank page problem is solved where you have everything structurally placed for you. So I'll just give you a small example of what currently we are building and what the future will look like. So you can have a patent application, you can have a prospective article, a conference abstract, a case report, whatever you want to choose. All you have to do is type in what does your content look like? What are you writing about? And give a short summary of your abstract of what you want your case report to look like. Then you choose what your resources are. What do you want to use? You want to use genomics, oculomics, depending on the structure of the question. And then use a structured format of whether you're an IJO article, whether a Lancet article, depending on that, and write your plan. Automatically, it generates a case report that you need to generate according to a structured thinking pattern that we have individually done for our system. And this thinking pattern gives you actually why it does, how it does. And the system data never leaves your system. It stays within the eye care system, within the institution. It doesn't go to any ChatGPTs or Claude or any other places where your data might be lost. So this kind of writing is what we see nowadays. And this is where we think it will lead, making sure that the researchers have the right idea and the tool to use their idea into original articles or research paper. So it is not about what you know, it is about how you use what AI knows. So that is what I will leave you with. And if you have any questions, I'm glad to answer. Thank you, sir.
Thanks, Karthik. Maybe because of the time I'll ask Tulsi and Vijay Madam, Dr. MS sir to give some short comments before we close. Dr. Sujata, over to you. So
it was a wonderful insight into the heart and the pulse beat of ARAVIND Eye Care System. What we saw is only the tip of the iceberg, and now we know so much of work is being done inside the research, the innovations, and the motivation, the HR work. And it is really amazing to see this this all in about a matter of 1.5 hours. And I'm so happy that you accepted to participate in this, and this is going to be an eye-opener. I hope that because it's archived, I hope more and more people see this presentations and benefit by this, because it's so motivating for youngsters as well as people like us who have small hospitals, and how to motivate your staff and how to do innovation, how to do research, and how to take care of your patients. I think it is an absolutely wonderful insight into ARAVIND Eye Care System. I'd like to request our Honorary Secretary, Dr. D. Chandrasekhar, to give the final vote of thanks. Thank you, sir.
thank you.
Yes, sir. RDS, sir, can we ask Tulsi, sir, MS, sir, Madam?
Yeah, Tulsi,
Yes.
you want to say any closing remarks?
Yeah. I think first we should thank TNOA, Dr. Sujata and Chandrasekhar for this opportunity. I just want to kind of acknowledge, for anything to any institution or individual to flourish, the ecosystem is important. And I think in Tamil Nadu, we are particularly blessed to have the right kind of ecosystem, and especially the eye care fraternity, which is very mutually supporting and engaging as well. And then we've been engaging with TNOA on multiple fronts, organizing the practice management courses and many other things. So we are grateful for this opportunity and for the association. Thank you.
Thanks a lot. Okay. Thanks. I think Chandrasekhar, we can.
Yes, sir.
Yeah,
So actually, it has been a mind-boggling session, sir. First, I'd like to thank our president for this innovative thinking on iconic institutions, which has it actually changed ophthalmic practice. And this presentation has thrown so much of light. This is going to be in the YouTube for a very long time. And I'm sure not only ophthalmologists, administrators, and leaders who are owners, everybody have got something or other to learn. It has been so informative to see a 5-decade-old organization which has grown from 11 bed to what a massive institution, the biggest in the world today, sir. And thank you so much to the leadership, Dr. Adia, sir, Dr. Tulsi, sir, and everybody else, experts here, for their wonderful involvement and their talks. Thank you once again on behalf of TNOA for this wonderful program, sir. Thank you so much, sir.
Thank
you all.
Thank you. Thanks, Dr. Sujata.
Thank you, sir.
Manjula, you can stop YouTube.
Thank you, Dr. Sujata. Thank you.
Thank you.
Thank you, madam. Thank you.
Manjula?
Just a moment.
Yes, Sai.
Okay. Okay, thanks.
Thank you, sir. Thank you, sir.
I think we really tried our best to keep it to 1.5 hours. I look